Jeff has strong ties here to the University of Chicago. For more than a decade, he was a lecturer on health services management and policy at the Booth School, which was then called the Graduate School of Business. And Jeff also worked in our own dean's office here at the university as a special assistant to the dean of the Pritzker School. Jeff has served as a national advisor for healthcare at Ernst & Young, providing strategy consultation to many different healthcare systems, and worked after he left the university for the governor's office in the state of Illinois as a special assistant to the state budget director. Jeff has written widely on healthcare issues and policy questions. We have a wonderful panel of respondents to Jeff's talk. Anoop Milani is from the law school, and you all know David Meltzer from the medical school, Jeff Glassroth from the medical school, and Elbert Wang. I want to thank the panel very much for coming. I think I'm going to ask Jeff to start, even though they may be replacing the cable. I'm going to stand first. Jeff?
Right. Now, this is sort of applied neurosurgery, right? Is that you need connectivity in order for things to work? Are you the person with the cable?
See if I can adjust this.
Oh, that would be fabulous. Well, you know, as Mark indicated, I'm sort of like a quadruple alumnus of the University of Chicago. I did doctoral work in the social sciences. I went administrator in the dean's office, and then a consultant to a subsequent dean and vice president for this place. I was also a research assistant in the School of Social Services Administration at across the Midway, and a teacher in the business school, and then, to bring it full circle, last year a patient at this institution. So I'm deeply grateful to the clinicians of this place for ridding me of throat cancer quite successfully. So I'm particularly happy to be here for a whole bunch of those reasons. So what we're going to talk about this afternoon is, I don't think healthcare is unique in that it is, like other fields, subject to waves of groupthink. People go to the same meetings, they hear talks, they repeat what they hear in those talks, and that groupthink morphs into a consensus about what's happening in the field without a lot of direct connection to data. And that's troublesome to me, because I believe not only that health policy ought to be data-driven, and propositions about what's going on in the field be subject to empirical test, but also that strategy in institutions like this ought to be data-driven and subject to empirical test. So that's the challenge that that I'm going to lay out for you now. And of course, everybody knows what's going to happen to our health system, right? Everybody knows. Health costs are growing out of control, and in order to control them, we have to change how doctors, hospitals, and other caregivers are paid. Our health system's payment models are moving from volume to value, are moving from per incident payment to population-based payment. And that if care systems are to cope with these changes, we're going to have to change our emphasis from treatment to prevention. Our health system, rather than being characterized by a fragmented structure of hospitals and physician groups and health plans, is going to evolve into models of integrated care, where the very same organizations that deliver hospital care also employ physicians and insure patients. Due to the press of time, we're not going to be able to get to this one. Disruptive technologies will undermine the traditional business of healthcare, forcing transformative change. And then finally, consumer empowerment will strengthen the role of consumer choice in the health system and rearrange the power relationships in medicine, shifting more power to the patient. But what if the crowd is wrong? Well, I think it is. And the question I'm going to be asking this afternoon is, well, what difference does it make? Suppose these things don't happen. What does that change for clinicians, for patients, and for large complex institutions like this one? Well, here's the first one. Health costs are rising uncontrollably, and to control those costs, we have to change how care is paid for. We've been told incessantly that we need to bend the curve. That is, we need to reduce the rate of increase in health spending. This purple dotted line is the curve everyone's talking about. You do not need a doctorate in statistics to see that it is, in fact, bent. It bent down 13 years ago in 2003, and by 2009 reached a level that basically we haven't seen, a level of increase we haven't seen since Dwight Eisenhower was president of the United States, 5 years before Medicare. It stayed there for 5 years at this pre-Medicare rate of increase, and of course if you take out population growth and inflation, this is virtually a dead stop. Now we busted the trend a little bit in 14. According to CMS, we bumped up to about 5.8%, but when you look at what produced that deflection, you see the core of the health system, the 60% represented by hospitals in blue and physicians and clinical services in this sort of sick yellow color, remained in the low 4% range. The biggest contributor to that increase was an 18.5% increase in the federal share of Medicaid, which was driven by Obamacare, or the Affordable Care Act, 18.5%, to expand the Medicaid program with 100% federal participation. The other big outliers that drove this average up were the cost of government administration, again, getting ready for the Affordable Care Act at about 8% a year, a big increase from 12 to 13. A single drug, Sovaldi, the Hep C drug, followed closely by Harvoni, the combination therapy. This really was a single drug, the biggest blockbuster drug we've seen in our professional lifetimes. And the biggest contributor of all in absolute dollars, the net cost of health insurance, which is the spread between what health insurers charge in premiums and what they pay out to you all to deliver care. It's important to add that even with the expansion in coverage that we got in 13 and 14, that the core cost in the health system remained at that roughly 4% level. So, to argue, and remembering fee-for-service, the alleged reason why health costs have been growing out of control for most of our professional lifetime, so it's pretty much intact the entire time. So I have trouble with the diagnosis that the principal driver of health spending was the way in which we pay doctors and hospitals. I think there were other things at work. And of course, a social scientist, a sociologist or whatever, a political scientist might disagree with an economist on what the root cause was. These were, I think, temporary contributors to that decline in the rate of growth. I say temporary because they've largely passed. And these were the big suppressors, a pause in device and imaging innovation. I think a big sleeper here is the retirement of an entire generation of 80-hour-a-week workaholic baby boomer docs, a big shift in risk to consumers through almost a quintupling in high deductible health plan enrollment, and I think lurking in the background and the biggest suppressing force of all, what I call the affordability problem. You think about this. Before the Affordable Care Act went into effect, before we began enrolling people in coverage, there were 43 million people in the country that lacked health insurance. But another 40 million or so, even though they had health insurance, had deductibles that were sufficiently intimidating because they didn't have any cash, they didn't use care. I think that had a very significant effect in suppressing demand. And indeed, there was a recent research study that suggested, studying people that transited to high deductibles, that they didn't shop for care, they didn't discriminate between high value and low value care, they simply used less, which is actually a consistent research finding that goes back to Joe Newhouse's RAND study in the late 70s and early 80s. And then there's 1 million people on Medicaid, going to 80 million in the next recession. Add up those three numbers. Well, it's almost half the country. I would argue, I'm not an economist, it isn't bullish for an industry if half the country can't afford to use its product without massive public subsidy. Now, the Milliman, which is the health insurance actuarial advisory firm, says that if you add up the cost of premiums contributed by employers, premium contributions by individual families, and out-of-pocket spending, the average medical cost for a family of four in the United States in 2015 was almost $25,000. Now, as we'll show you later, there's a huge dispersion around that average. Something like half the families in our country spend almost nothing on healthcare in a given year, and 1% of those families will spend roughly $90,000 in a year. So there's huge dispersion around the mean. And of course, no one needs to explain to me the difference between a mean and a median. The median family income in the United States for a family of four is 53 grand. So the fact that there's this level of risk, this sort of mean level of risk, is the reason why we have health insurance in the first place and why we ought to have universal health coverage. That's how big the risk is. So what if the crowd is wrong about the rising cost? I think health policy has made an incorrect diagnosis of why costs were rising in the first place. They're not growing out of control. Core costs are essentially flat in real dollars. And that once you take the cost growth emergency off the table, it's astonishing how little consensus there is about what type of problem we ought to be solving in health policy. In my opinion, as one actor in that system, I think affordability is the main challenge, not cost growth. And that to tackle affordability, as Bernie Sanders has conclusively demonstrated to us in the last month, you've got to take resources away from people. Powerful institutions and professionals need to have their incomes diminished in order to get the cost of care down, hence a politically fraught objective. We'll see how successful we are in pursuing this. So my argument to the people that run places like this is clinical leadership and managements are going to have to figure out how to create value and earnings, which are important, inside a low single-digit revenue growth envelope. I do not believe that the pause in cost growth is over. And I think once we get through this pulse of spending, that new normal is in the low to mid fours. And I'm going to love the discussion about this because I'm not sure everyone agrees with that. Here's the second one. Population-based payment is the future of healthcare payment. If we want to get costs under control, we're going to have to get rid of per incident payment with the apparent incentive to encourage people to do more, perhaps, than people need, with per capita payment for a defined population. That's essentially what capitation is. So a fixed amount of money, hopefully severity adjusted, per person, spread across a defined population, gives you a fixed resource pool that care systems must work to manage and make choices in order to make the patient and the care system come out whole at the end of the year. Accountable care organizations are a forerunner of capitation and will evolve into them over time. Commercial insurers will have to follow or be hit with a ruinous tide of risk shifting, cost shifting, and that what is called today value-based payment will also eventually evolve into this type of per capita model. Well, this movement of evolution or shifting of risk isn't going very well. Unfortunately for the Obama administration, CMS made the Accountable Care Organization Shared Savings Program the centerpiece of its demonstration projects in payment and delivery system reform. And to put it mildly, it hasn't gone very well. The initial cohort of these folks, which were among them the most sophisticated care systems in the country, in actually managing population-based health. 3/4 of that initial cohort of 32 institutions dropped out of the program. Managed care veterans, many of these people that run these are friends of mine, either struggled with this program or left. The total amount of cost reduction in these pioneers was only 0.6% relative to the Medicare trend for the communities as a whole that they worked in. In the larger program, the Medicare Shared Savings Program, 3% of the 420 Medicare Shared Savings participants generated half the savings. 15% generated 80%. This has been a consistent finding that the performance of these organizations is extremely concentrated in a small number of institutions that also, I don't believe entirely coincidentally, are concentrated in communities with extremely high rates of per capita Medicare spending. In the Pioneer program, 42% of the savings came from the city of Boston. Believe it or not, one market. our nation's most expensive medical care. The regular Medicare Shared Savings Programs participants have been fighting the agency pretty much all the way along. A third of the first cohort to come up on their renewals for the program dropped out in December. They were replaced by new people that came in, so the total number of Medicare ACOs has stayed about the same. The biggest issues were the way in which patients were attributed to ACOs, largely as a statistical artifact rather than patients making a choice of a care system. No control over out-of-network costs, so if people want to jet off to the Cleveland Clinic or Mayo Clinic to get care, they can do it and you get their costs at those expensive places attributed to you. Serious problems with risk adjustment and adverse selection. Organizations like this that got involved in, your peer or sister institutions that got involved in the ACO were victimized by the fact that you have reputations for dealing with the sickest patients in the community, and those weren't adequately reflected in how the data was organized. The data itself was terrible. I see dead people in my panels, people kept saying, and a CMS staff full of eager young people that know very little about what you guys do on a day-to-day basis. All of this hurt, and I don't think it was just the ACO. It's astonishing how few of the CMS Innovation Center projects have actually paid off. There's been one big surprise winner, and that was the Independence at Home demonstration project oriented towards keeping severely chronically impaired people out of nursing homes, saved about $3,000 per capita. That's just about the only really big victory in the whole portfolio of ideas that CMS has been working on. I'm pretty confident to say that the Medicare Shared Savings Program is not going to be a total replacement for regular Medicare. In the meantime, Medicare Advantage, an established program that basically enables Medicare beneficiaries to get Medicare services through private health plans, has been growing at 10 or 11% a year and is now a third of the people in the program. So risk is going to be shifted in the Medicare program, but it isn't necessarily going to be shifted from Medicare to care systems. It's going to be shifted from Medicare to health plans with a great big question mark about how they pay all of you, and not a great deal of consistency there. The commercial ACOs were mostly created to offer narrow network products through the health insurance exchanges that were created by the Affordable Care Act. According to Brookings last year, there are about 15 million people covered by these commercial ACOs. 90% of them are so-called one-sided risk, which means that there's an incentive to reduce the rate of increase in spending for that population, but no penalty if the costs go beyond the target, which basically means that fee-for-service continues in the background. Even if you don't believe this is as potent a driver of costs as I do, this obviously affects the differential incentives of the various actors in an ACO to participate. So there's potentially a lot in it for primary care physicians. If they get a bonus, it's a significant percentage of their comp. For the cardiologists and interventional radiologists and specialists, and frankly, for a lot of hospitals, not so much. The entry ticket into these commercial deals was a huge front-end discount. 25 to 30% was fairly typical, with a multi-year rate cap, meaning that you committed yourself to not raising your rates by much more than the rate of inflation for 3 or 4 years. What this really was a withhold with an earn back for the ACO if it met quality metrics and spending targets. In other words, virtually a no-lose proposition for insurers. And despite the fact that it was a no-lose proposition, a significant fraction of insurers are still losing money on these products. So even with this huge upfront cost concession from the care system, a lot of these organizations, including Blue Cross plans, are losing hundreds of millions of dollars on these products precisely because of the adverse selection problem that we talked about a moment ago, is that they were sampling out of the uninsured population a significantly higher percentage of really sick people than they expected, and even with the rate concessions weren't able to charge enough to offset those costs. Actual capitation, per capita payment for a defined population that creates a fixed pool, is at best 5% of total health care, private health insurance payment in the United States. And if you look at the percentage of hospitals, this was from the AHA survey data that came out about 2 weeks ago, A grand total of 8% of the hospitals in the United States have any capitated payment whatsoever, a number that's actually a third lower than it was 13 years ago in 2003. So if there's this massive shift to capitation, it's not obvious where it's occurring because you can't see it in the data. So my bottom line is don't hold your breath on population health. There are clusters of the country that are committed to this approach. The state of Maryland is using a population-based model for its rate review system. The state of Massachusetts, about half the HMO population in the state of Massachusetts is capitated. A significant chunk of partners' revenues are capitated revenues and contracting with Blue Cross, Tufts, and the Harvard Community Health Plan. But as far as the ACOs are concerned, it's about 7% of the population of the US is presently in them. That rate of growth is leveled off, and only 25% of the hospitals. And only about a fifth of this 25% are actually generating any savings to offset the billions of dollars that they've spent creating these things. So the society is still a couple $2 billion in the hole on this idea. It's also been the most spectacular management consulting franchise in the history of it. My friends in the consulting world refer to the ACO as, quote, an awesome consulting opportunity, to give you some idea of how good a deal it was. As we said earlier, only 8% of hospitals report any capitated revenue, and those are mostly in Massachusetts and Southern California. I don't consider thief or check the box, which is bonuses if you meet quality metrics, mostly process measures, to be population health. I also don't consider a one-sided ACO to be population health, because the essence of population health is a fixed envelope of resources that you have to allocate more sensibly. But the key thing is, Blue Cross here in Illinois has what, 50% of the commercial market? Why should Blue Cross share risk with the care systems in Illinois? They're making money, for the most part, under the system that they have, which is fee-for-service with a huge overlay of 1-800, you can't do it, utilization review systems laid on top of them. In other words, the crude systems that they're using are sufficient to keep their medical loss ratio, or their medical cost growth, in the 5 to 7% range. So when I go to like Tuscaloosa, Alabama, or Jacksonville, Florida, I ask the people there, doctors and hospitals, okay, forget about what's going to happen in the country, you know, the bunny rabbits are coming, whatever, who in your market is going to capitate you? The only answer that I get in most of the places I go is Medicaid. And Medicaid is capitating them at 60 or 65 cents on the dollar, which is a level of payment that is basically just triage. Managing it is basically a question of trying to limit losses and limit bleeding and stretch a small amount of time. Say again? 10 what? Okay, we're working on this. Well, I actually said 40 minutes, so it'll be a little bit longer than that. So what if the crowd is wrong? I don't think the current payer contracts are going to evolve into population-based payment, and meanwhile hospitals are squandering their margins in network contracting to avoid losing market share. And they lose sight of the fact that they get to keep 100% of the savings that they generate by managing the inpatient cost for Medicare patients and the cost for their own workers. They don't have to share those savings with anybody. Clinical value and safety improvement is the best strategy under any payment scenario, and I would also argue a moral obligation. And bundling and episode-based payment seems the most likely evolution of Medicare payment policy. Oh boy, you can't read this at all. The big problem here is that the minority of most episode costs are in the initial hospitalization. So this is a cardiac valve replacement. This is, God, I can't even read these. That's a bad slide. But the point is, these are all complex clinical encounters where in only one case was the initial hospitalization even half the cost. So the issue of how do you coordinate the rest of this stuff is really the heart of the matter, and it isn't just reducing readmissions. It's a whole lot more complicated. It's making sensible use of all of that post-acute stuff. Here's the third one. Providers will have to shift from treatment to prevention. Here's our baby boomer icon, Smokey the Bear. This is the part that really bothers me. This has really become politicized, this whole idea of prevention. There's a right-wing version of the whole prevention narrative, which is that illness is basically the patient's fault, and if they just had more skin in the game, they'd take better care of themselves. So if everybody had a high-deductible health plan, well, then we wouldn't have any obesity. People would stop smoking. Give me a break. And then the left-wing version, the progressive version, which I find equally irritating, which is that illness is really your fault. By waiting until people get sick, you make more money. If we just pay you differently, you'll figure it out and make people healthier. And this is what has led, in my judgment, to this futile and stupid pursuit of the perfect operant conditioning schedule, that if you just create the right incentive set, doctors will do the right thing, costs will come under control, and quality will improve. I think this is magical thinking. Both of these models blame health cost growth on moral failure by one half of the doctor-patient relationship and basically reduce you all, whether you are doctors or patients, to cartoon caricatures driven by purely economic motivations. I find this really troubling. Why is it so hard to get people engaged in their own health? Well, my friend Alex Drain put it really well. She said if you've lost your job and are 4 months behind on your mortgage and your marriage is falling apart, managing your hemoglobin A1C level may not be your #1 agenda item. There's a whole Maslow's hierarchy problem here. Tom Roberts from the University Hospital Consortium, in looking at claims data from a lot of under 65 folks, 42% of the costs are from single events that are not preventable by the health system, and another, roughly a third are from advanced, i.e. incurable chronic diseases. That's 3/4 of the cost for the people under 65. Well, of course, you get over 65, and you probably double the number of problems that are, driven by advanced incurable chronic disease and the crises that inevitably ensue as those diseases creep up on us. This is the data that everybody sees about the distribution of expenditures. You can see how skewed it is to the high side. A tiny fraction, 5% of the population generates 50% of the cost. You've seen this over and over again. But what I don't think people get is how heterogeneous that 5% is. Look at the variation in the clinical problems here. So the idea that a single silver bullet, medical home, give them all medical homes, each one of these folks has a different cluster of clinical risks that probably requires a different care model. And the real art form is fitting the care model to the risk, not just making sure that they have effective primary care. And of course, these are the folks that you can't really predict very well, where you don't have a lot of preventive leverage except for getting people to stop smoking. So what if the crowd is wrong here? Well, I think it is as well. This is a very unpopular thing to say, but I believe acute intervention and critical care are still the hospital's core business and will so remain. And I don't believe that's just inpatient care. A lot of that intervention is increasingly ambulatory or short stay. And the primary prevention doesn't make a lot of sense for a hospital system, even an integrated delivery network, and really questionable even for the carriers. Secondary prevention sure does, which means that when these folks fall into your system, the opportunity to do less harm, to effectively organize, to deal with their risks, and to get them on their way and hopefully back to a decent level of functioning, there's an enormous amount of potential societal benefit and patient benefit to doing that effectively. I don't think medical homes are going to cure obesity or alcoholism anytime soon. And the real issue here is fitting care models to those subpopulation risks, where we have an enormous opportunity to do a better job. And this is a normative statement. Some of you are going to disagree with this, but I think with some exceptions, most docs will never care as much about the patients they aren't seeing as the patients that are in front of them. Indeed, it's how you're trained, is to focus your attention on the people that present themselves to you in extremis. I think the serenity prayer is sort of essential here. What can we control that affects the patient's health? And where's the real leverage to improve people's health? This graphic is from my and Mark's common mentor, Al Tarlov. And of course, there's a lot of different versions of this graph, some of which attribute only half of the health status of a population to societal and social characteristics, like poverty, a lack of education, violence, food deserts, you name it. We haven't done a very good job of managing those. The conservatives want to focus on the maybe quarter of the total picture that is health risks generated by individual behavior, and the progressives want to focus on you all and find that perfect operant conditioning schedule. I think this is incredibly frustrating. If you want to move the earth, Archimedes said you need a lever and a place to stand. And while I really like Don Berwick's idea of a triple aim, I think these are the three right things that if we were trying to manage the health system as a whole, you really want to focus on. The leverage question is, where's the leverage for the care system to move these things? We've got a lot of potential opportunity on patient experience. We've got very limited opportunity on per capita cost. You saw the portion that's really hospital and clinically driven, and I think very little leverage to actually affect the health of a population. So if we really want healthy populations, if we really take this seriously, we need a healthier and more just society and a more vibrant economy that creates opportunities for families and that generates wealth that they can use to reduce their risk, and more intact families and a much more robust investment in public health. To argue that by changing how the private care system is paid, you can do a job that you could argue our political system has defaulted on for most of the last 30 years, I think is asking more than it is appropriate of you to ask. Health systems will organize integrated delivery networks. I mean, I'm almost out of time here, Mark. This is the front of the Mass General Hospital, one of the warm, fuzzy places in our care system. You can see it's a real warm, fuzzy place. We've had 40 years of this idea, the idea that, you know, the integrated delivery network would cure fragmentation in the care system. The IDNs will provide coordinated services across the continuum for a monthly premium, and basically have multiple Kaiser-type organizations in every market. And the care system would exist inside that fixed pool of capitated dollars. The patient's role is mainly to choose the most cost-effective IDN and stick with it. We've had waves of development of these things, including a couple here in Chicago that are no longer in the health insurance business. Rush, and in one case, Michael Reese, that even isn't here anymore. You look at the literature, it's really kind of depressing. There's no evidence in the literature that these things either lower cost or improve care coordination. Physician employment by hospitals, which is a key element of integration, the idea you no longer have private practice, the doctors are salaried, appears to have raised not only physician costs, but also hospital prices and overall per capita spending. Larry Castellino and Jamie Robinson are the principal investigators on this stuff. Health plan sponsorship has actually been a significant net loss to most care systems. Partners lost something like $100 million on the neighborhood health plan. It's scary stuff. My colleague Rob Burns, who trained here, and I analyzed these critters in 2015. It was impossible to determine where the money came from or where it went based on their public disclosures. You couldn't see where money was being made and where it was lost. There was also no way to tell the ones that had health insurance, did they retain the risk in the health plan, or did they sub-allocate it to the care system? A lot of the care systems were actually paying their docs under an RVU, where they're actually incented to do more, but retaining the risk in the health plan, which is not integration to me. So what if the crowd is wrong? I see a compelling value-based case for these things, but no business case for the payers or competitive advantage to the providers, and that we had strong indications that the total cost of care is probably higher in most IDNs than it is in competing institutions that aren't as completely integrated. And of course, if that's the case, this is still a hypothesis. This is something we'd like to test more rigorously. Then why should the payers share premium with them? Why should the payers pay them on a capitated basis if they're actually more expensive than the rest of the care system? And there's no evidence that they're doing a better job of coordinating care. I don't see the offset for the complexity and transaction costs of becoming an IDN. And I'm not sure what the patient's value proposition is for choosing one. This is my final proposition here. Consumer empowerment will strengthen the role of consumer choice in the health system. That's me at Walmart. I can tell you, as a person that spent a good portion of 2015 being a patient, I can tell you the greatest dissonance was in this idea that I was somehow during that time where I was struggling to regain control of my life, even remotely a consumer. When I think about consumers, I think about somebody going through a cafeteria line and saying, oh, I'll have some of this, I'll have some of this. That's not what I was doing at all. I was drowning for a lot of that year and working hard with my clinicians to try and get back to a healthy place in my life. The idea that I was somehow a consumer, that I was kind of, trying to maximize my benefit under my existing Medicare Advantage plan just really didn't correspond to what was going on with me. No, we really don't have time to get into this stuff. But the key thing that we need to know about consumers is that they're still broke 7 years after the crash. You ask why we have a hardcore socialist and a hardcore totalitarian as our leading presidential nominees, that might have something to do with it. There's a lot of trouble here 7 years into this recovery. And I think there's a big moral and ethical conundrum about, are you empowering a person with no savings by selling them a health plan with a $5,000 deductible and a $7,500 out-of-pocket limit? I think this is a really bizarre thing that we're doing and not a healthy thing. If you're creating enough economic risk that people aren't filling their prescriptions or renewing them, if they're not getting care that their clinicians in their best judgment believe is needed because they don't have the money, there's something wrong with the model. Moral failure or not, I think the real moral failure is in propagating these models. And according to the Kaiser HRET survey, since 2010, patient cost sharing has risen at 6 times the rate of people's salaries. So the amount of shift of risk onto household budgets in this last 6 years has been truly horrendous. So what if the crowd is wrong? Well, I don't think it is here. I think satisfied patients will move markets. But the majority of their families, patients and families, are effectively broke. So the key question for carriers and providers is, how can you save them money? And how can you create a patient experience that causes people to come back and to tell their friends? And will employers choose to share the savings that are created by doing so with consumers? So there's been some kind of grim stuff here. I don't want to end on a grim note. There's a lot of sort of Job's daughter stuff about our healthcare system, you know, and the idea that we're spending all this money, what are we getting for it? There's a consistent strain of belief that a lot of that money is somehow wasted. Think about it. We're on our way to cutting the number of uninsured in half. And it's a measure of how out of kilter our political system is that somehow this is a huge problem. Moreover, the 40-year cost panic is over. We've got problems in our healthcare system, but the fact that costs are growing at 3 or 4 times the rate of inflation isn't one of them. And I think for better or worse, the fact that the policy conversation is about value as opposed to merely cost is a good thing. That's a sign of evolution and growth. I also sense from my travels in the country, the Cold War between physician communities and hospital managements is thawing. Physicians in hospitals are talking constructively about things that were impossible to talk about even 5 years ago. We've essentially cured a major illness, Hep C. We're arguing about how much it cost. You know, as somebody of advancing age, I'm kind of like, let's cure some more illnesses. Let's cure Alzheimer's disease, for example. And then we can argue about how much it costs. Let's get busy and cure some more diseases. And we've also made sustained progress against the 3 major killers of Americans that absolutely no one appreciates. These are the severity-adjusted death rates from heart disease, cancer, and stroke. And even cancer, where there's a narrative in the policy community that we've somehow failed, a 25% reduction in the severity, in the age-adjusted rate of cancer deaths. And I think in 2005, the absolute number of deaths for cancer was also falling, even though the population is getting older. So what am I telling clinical and health system leaders to do? Well, they're going to have to learn to run on regular gas. 3, 4, 5% revenue growth is going to be the new normal. And that's going to impose real challenges, fiscal stringency, and a need to make choices inside the budgets. They need to reduce the number of layers between the C-suite and the patient. They need to develop a fault-intolerant clinical culture based on continuous care improvement, not blaming, but searching for shared objectives and clinical protocols and good judgment to smooth and light the patient's path through the care episode, to become the health system of choice in their communities and regions, and for places like this to teach young clinicians elegant diagnosis and resource-sensitive clinical care. My last slide, when I got sick, this is how I wanted the care system to feel. You think about all the people that come here in extremis, what do they all have in common? Look at all the diversity in life chances, in race, age, income, whatever. Look at all that diversity. What do they all have in common? I can tell you what they have in common. They're scared. And they come to you and put themselves in your hands and trust that you will do the right thing. That trust, not economic caricatures of how people behave, ought to be the foundation of a sensitive healthcare policy. Thank you all very much for having me here.
Jeff Glassroth will be the first respondent. to Jeff's comments. Please, Jeff.
So as one Jeff to another, Jeff, let me first say I really enjoyed listening to your comments. When I was invited here to be a respondent, Mark didn't insist that I either agree or disagree with you, so I'll do a little of both. Mostly agree, actually. I think your view of many of these things is consistent with my own. I would quibble about a few things. I think a lot of the things that you posted, your 6 things, what if they don't happen, I think for the most part they'll continue to happen to some degree, but they're not going to have the impacts and the consequences that everyone dreams of. In fact, I would say there's a real chance that they will have almost the opposite impact. So disruptive new drugs and technologies will continue to arise, just as they have now for a few hundred years in small and large ways. But if you think about it, there are very few Harvonies that cure a disease. Most of them, not all of them, but most of them convert acute or subacute diseases into chronic conditions and actually extend, for, in some cases, for many, many years, the cost of managing the disease. HIV is a perfect example that we're all familiar with. That's a good thing. It's wonderful that these people can live decades now, whereas they would die within relatively few years of their diagnosis in the 1980s. But the cost is clearly now much, much higher. The electronic medical record, which was going to save expense, has not only not saved expense, it's added hundreds of millions, billions of dollars, created a whole industry, and will leave aside the human impact on those of us who labor late at night with recalcitrant electronic medical records trying to get our notes done before people like me complain.
Crack the whip.
You didn't really comment at great length, you didn't have much time to, on the aging population. And while those of us of an age and a cohort who are leading the edge want to think that we will all age gracefully and well and go quietly in our sleep after 70 or so, that isn't going to happen. So there are going to be more sick people. They may become sick at a later age. They may do well longer, and I think that's a very real possibility. But eventually, as the saying goes, the mortality rate is 100%, and we will all go, and something will happen, and more than likely it will include generating a fair amount of expense in some health care system somewhere. So what's my sense of all of this? I think I would quibble again with you about primary prevention. While I think it has to be rationally applied, I am a victim of having spent a couple of years in the public health service at the CDC. I really believe in primary prevention, and a lot of it is incredibly cost effective. So vaccines, about which we have these huge debates today, are by and large wonderful, life-saving, health maintaining interventions that are extremely cost effective. There are other things not so much. Seat belts, that's a primary prevention, great intervention when used and applied. Not smoking, as Mark is telling this pulmonary physician, is a great primary prevention that not only doesn't cost money, it saves money.
You saw that decline in cardiac disease.
I did. So what's my recipe for dealing with all of this? I agree with most of the things you said. I would underscore a couple of things, though. I just said a moment ago that I'm a pulmonary physician, and for a large part of my career that included critical care. And so I've seen more than my share of patients in extremis on ventilators, in these incredibly expensive environments where the meter is running hour by hour and costs are really being generated. And I've also seen a lot of things that disturb me about the way we make decisions about expending those resources. And I want to be very clear in what I'm saying. I think these are wonderful places, wonderful interventions that have saved thousands and thousands of lives and will continue to save lives. But there are patients who we can't help at any point in time because the state of the art or the state of their disease is too far advanced. And as a society, we really haven't yet come to grips with how we're going to allocate our resources. Call it rationing, call it allocation, call it whatever you want. There is a need for us as a society and as individuals to begin to confront some of these discussions in a way that leads to better decision making, both by the healthcare providers, but most importantly by families and by individuals. Our ability to predict outcomes for many conditions now has become extraordinarily good. It's not perfect, and that's the problem. And everyone wants to be in the couple of percent that will deviate from the dire prognosis, and we can't yet really deal with that. But we do pretty well, and we can give people a very good sense of where they may be heading, and it really is incumbent on those of us who are providing care to provide a frank and honest and understandable assessment of the situation and what the options are. And it's important, I think, for all healthcare consumers, which will be all of us at some point, to make thoughtful decisions. And that really is a societal discussion that has by and large not gone on. In Oregon, it's gone on to some degree, and it was squashed to a very large extent, and it's gone on in pockets elsewhere. But it is a really important thing. Having advanced directives that we all write for ourselves when we're not in the midst of confronting something or getting close to perhaps confronting something is another intervention that is very, very important. And as someone who's had to deal with uncertainty because there was no directive and we were kind of guessing at what patients might want, where families were debating among themselves, sometimes heatedly, it's a really important intervention for us to take. So the world is not going to get easier. It's going to probably get harder, and we're going to try a lot of things that don't work and some that do. But this discussion, I suspect, will still be a vigorous one some years from now. Thank you.
Anoop Milani from the law school.
So, like Jeff, I'm going to agree with some things and disagree with others. I want to talk about 5 things, I think. But before I begin, some of these things that Jeff talked about were thoughts that we had and concerns that we had or beliefs that we had before the ACA. And in the, one of the interesting things during my career, I've seen the pre-ACA period, the run-up to ACA, and then afterwards. And what I found super interesting is that politics played a huge role in our academic discussions. There was such a push to get the ACA passed that we changed our message. We forgot about things that the literature had already told us just because we wanted to get the ACA passed, and now we're rediscovering them. And in some sense, that's sobering. That tells me that the politics changed our academics and what we were saying, and we're just discovering stuff from before that we were, we ignored because of the politics. I hope that that doesn't continue to happen. Because it can lead to sometimes, experiments that may not work out as well as we want, just because we're excited about a new policy. So here are the 5 things. The first thing is I want to clarify that we're all in agreement, I think, that there are very important non-healthcare interventions that can be undertaken, meaning stuff that's not done in the hospital, not done by anybody that's in this room, can be done by, in retail clinics, that have or by me individually as a non-doctor, that has a huge impact on health, and perhaps a larger impact on health than anything we've talked about here, both on healthcare costs and health. And I think that's great. So seatbelts is an easy example, but smoking and vaccines is something that you can do in a retail clinic. And that's an important thing to remember. While hospitals spend a lot of money, maybe it's the individual decisions that people make that have a much bigger impact on health. And what we care about is not health care, we care about health. Second one is innovation. So again, we talked about how awesome it would be, the Hep C cure. It'd be great to cure Alzheimer's. Big innovations in treatment for heart disease. Also big innovations for HIV. They're all innovations, right? And it's not the treatment that was the key. It was actually the innovations. The innovations drive a huge amount of the reductions. After we talk about individual behavior, innovations drive a huge effect. And I think we want to not forget that. Because one of the things that we don't see so much in the ACA, and we're not talking about, is what sort of interventions investments we make in that innovation. And here I have a dog in the fight simply because I have a paper with one of our graduates, two of our graduates, Dry Slaktawala and Julian Rafe, where we point out that actually a lot of the insurance that we see that people get comes not from health insurance, but from innovation, which reduces the risk of living. So, if you're a person having sex before heart, you face a lot of risk. And as soon as heart comes around, you face a lot less risk. And that's not because the health insurance, it's because the innovations. The innovation that reduces the risk in your life, and that's important. So that's the second point. Innovation is important. It's not necessarily the health insurance. The third thing is that I'm not, so here, I'm torn on hospitals. So one of the most interesting studies I've seen on hospitals in the last decade is by Amy Finkelstein at MIT and Chad Syverson here at the Booth School of Business and some co-authors. And what they did is they tried to compare the efficiency of hospitals. Hospitals have there's physicians, there's staff, there's insurance, it's fragmented, there's lots of regulation. You think it's super inefficient, but as it turns out, hospitals are about as efficient as other areas of the economy that we think are subject to a lot of competitive pressure, like concrete manufacturers and things like that. I would encourage you to read that paper. It's actually quite refreshing. It's shocking that in a world where, when I come in, I go, oh my God, this is so fragmented, that in fact you guys are actually quite efficient, or at least as efficient as other manufacturing in the US. Now that said, it's kind of weird to say, oh yeah, it's good to continue the fragmentation. We shouldn't have some sort of integrated delivery network or capitation that encourages efficiency on the part of hospitals. Not because it's taking risk away from insurance companies and giving to hospitals, but because it encourages hospitals to be more efficient. I mean, everybody should have an incentive to be a little bit more efficient, I think. And so what I'm interested in is understanding, and I'd love to get Jeff's feedback, why is it that Medicare shared savings failed? Why is it that that integrated delivery networks are not successful? And you can tell an adverse selection story that the sick guys come over to these networks, but I don't think that's a full solution, because then you're not comparing what the cost of treating those guys were wherever they were treated before versus where they're treated now. So I want to know the answer. That I think I would love to hear your thoughts on. Last point is, we're overly focused on affordability. And here's why I think we're overly focused on affordability. We could go back to Joe Newhouse and the Rand health insurance experiment, and I tell my students year after year the same thing. The key finding was you could increase healthcare expenditures and it doesn't really affect health except for poor individuals. And for poor individuals, it is the case that if you increase cost sharing, they reduce utilization, and it actually has an impact on health. The Oregon health insurance experiment, which just finished a few years ago, basically gave you the same result. There was increased health utilization when people got onto Medicaid, but there wasn't necessarily any objective increase in health other than maybe some measures of mental health, but those were subjective. So that tells you something really interesting, that the affordability issue isn't affecting health except for the very poor, and those guys are covered by Medicaid for the most part. Right? So what is affordability all about? Is that the thing that we ought to be concerned with? And I'm not sure it ought to be. And the reason for this is the following, and this is going to hopefully cause some of you to gasp because you have a moral sense. I sometimes teach bankruptcy, and you know what's really cool about interesting about consumer bankruptcy? One of the arguments made for why we should discharge debt, consumer debt in bankruptcy, was that we said this is really important because if we didn't discharge the debt, all these people would end up on the public dole, and Medicaid would pay for them. And now we're saying the exact opposite, which is, hey, if Medicaid doesn't pay for these guys, they'll end up in bankruptcy, and that's bad. That's weird, because the reason why we had bankruptcy was intended as a social safety net. It is a form of insurance. It's just a substitute form of insurance. We just tend to think that it's a bad type of insurance compared to Medicaid. And it's not obvious that it's the case. So what I mean by this is that for the very poor, we've got Medicaid. For the people in the middle that are going to bankruptcy, we ought to think about bankruptcy as a form of insurance, just like health insurance is. It's just a different type of insurance. And once we see it that way, then we're not as going to be concerned about affordability, because we actually do quite well in terms of the safety net in the United States. And it's that fact that explains why it is that Oregon doesn't get, the Oregon health insurance experiment didn't find major health benefits, and it's why in RAND it's just limited to a small population. Okay, I'll stop.
Thank you very much. Albert or David? Albert? Go ahead.
Sure.
Albert Wen.
Mr. Goldsmith, I really enjoyed that talk, and I also agree and disagree with you on different points. I'm going to take a different perspective. One, I think that will help bind together some of the points I'm trying to make, which is, of course, something that a primary care doctor would do, which is to take on a life course perspective. And I think the failure to understand the life course, the natural history of diseases, the effects of treatments when we interact with people at different points in their life actually explains a lot of the failures that we've seen in experiments around payment reform, redesign of the healthcare system, and also is what bothers me most about what you said about the movement from treatment to prevention. And I think that one thing I would like to ask the audience is, who thinks about the life of the patient, the entire life of the patient? Well, yeah, you do, of course. But who in society does? Is it government? Is it hospitals? Is it doctors? Who realizes the gaps in care? Who realizes that it takes 20 years to see the effects of a preventive treatment? And the problem with the current healthcare system, and one that we will live with, is that people bounce around from insurance to insurance, from care providers to care providers. There's a lack of continuity across the life course of individuals, I think starting as early at, based on work from our Nobel laureates here at the University of Chicago, as early as in childhood, in nursery school. And without that long-term perspective, we cannot move the dial in terms of the overall health of generations of people. So I have this problem of always taking on this really long-term perspective of 10, 20 years. But if we really want to change things, I think that's the kind of perspective we need. Now, how does that, the problem is we have a forest fire, and I'm talking about preventing fires at the same time. And the challenge is, how do we navigate the ongoing fire that we have, which is chronically ill older people who are sick, sometimes for conditions that they have that are of no fault of their own, some that are, and how do we take care of them while also preparing the next generation for good health? So one question just for the audience is, and for you, Mr. Goldsmith, is who's responsible for that? If not the hospital, is it the public health department with its small budget, the Centers for Disease Control, which has absolutely no budget, a shrinking budget? Is it the NIH? Who is it that is, who is responsible for thinking about that? Is it the public? I was briefly in HHS during the second year of the rollout of the Affordable Care Act, during the discussions around ACOs, medical homes, all of these experiments. And as Anoop mentioned earlier, we sort of have this amazing ability to not remember what was done before and not to realize experiments that were done before. And in the case of the ACO, shared savings programs, and the medical home projects, what they didn't remember was that 10 years earlier, under Mark McClellan, they had done at least a $40 or $50 million investment in chronic disease management projects. My recollection is that 14 out of the 15 trials failed. Only one worked. It was one in Boston. And all of them, the one common theme with experiments done at that time and experiments done today is that the time cycle in which we expect results, reductions in costs, improvements in quality of care, we expect it to fit within 2 years. Why 2 years? That happens to be the term of a congressman. And so we are trying to fit political time cycles into improvements in healthcare that may take many years to accrue, and expect changes in people's health trajectories that may take actually at least 5 to 10 years in which to see. And we actually, the bizarre thing is, across the street from, if you go from Baltimore to Bethesda, which is not very far, we actually have clinical trials of prevention, secondary prevention, the management of diseases that are not actually translated, actually amazing work in geriatrics. We don't have work that is, we don't have actually transfer of knowledge from there to Baltimore at CMS. It is very weird, and one thing I do agree with you was when I was there for that brief period of time, there were almost no doctors. And CMMI was just a magnet for young, energetic people wanting to make a difference who had no clinical experience.
Right.
And
no management experience.
And I'm currently an external evaluator for some of the experiments out of CMMI, and many are not going very well, and we're not subject to the same, external review that we normally do for grants. For far larger budgets, I should have applied. And we've known that we can't do everything for the South Side of Chicago, for example, at the University of Chicago, but I feel like we have a moral obligation to do something in this area. We have what do we do when we have the clinical evidence and we know how to prevent diabetes, which we do? What if we know how to prevent lung cancer, which we do? What if we know how to prevent auto accidents, and we don't do anything about it? I think hospitals have some moral obligation to do something, and I think we're going to now have financial incentives to do something about primary prevention. I'll just end there.
Thank you. The final commentator will be Dr. David Meltzer, and then we will open for questions from the audience, because it's rare to have such a distinguished group sitting at the head of the table so knowledgeable about this subject. David, please.
Great. Well, again, thanks, Jeff, for great comments. And by going last, I get the benefit of also the wonderful comments of my colleagues. So let me take some of the key issues around which you thought maybe the crowd might be wrong in your questions around them. I think by and large I agree with you, but there are a number of areas where I think some different perspectives might also be useful. Where you began really was with this question of whether a shift to volume to value will really be good, and whether fee-for-service is really in many ways a driver of costs. And I'll just say that I think most health economists don't really believe that fee-for-service per se is the fundamental driver, at least in the short run. In the longer run, I think everyone recognizes that the incentives to invest, that technology is the driver, and that the incentives to pay for technology drive change. I think that has an important implication for some of the arguments that you made about how we should interpret this pause. Because the pause is really at this point a short-run pause, that's true, but it's a short-run pause probably in expectation of a longer-run pause that would come with this. And so I think that looking at this and saying, well, boy, we've seen a pause, but we haven't yet had capitation, so capitation isn't causing this, is a little bit of a misconstrual of what's actually going on. I think hospitals like this one are looking to a future where reimbursement isn't going to be as favorable, and are making capital investment decisions much more costly, much more carefully based on that. I'll also just point out that even if you believe that cost growth is not a problem in the United States, I think we can all recognize that cost itself is a problem in the United States, because we have enough waste in the system already that we need to deal with that. And finally, and other Jeff said this, but I think it's important, we should not underestimate demography. We have been protected by demography for a generation. That is now over. We're going to see the baby boomers moving into high cost, and just even to break even, given what's going on with that, is going to be a huge challenge. About your comments about capitation, I very much agree that capitation is not going to solve our problems. I think the fundamental dilemma here is that the vast majority of the money is spent by a very small fraction of the people, that the risk adjustment models that we have are absolutely terrible at capturing that risk. The best way to make money in the current healthcare system is to avoid caring for sick people, which is the worst way to save money and the worst way to produce health. So I'm extremely skeptical that we're on a great track there. Maybe a wonderful mathematician will solve it, but I doubt it. About prevention. I love prevention. I love it in concept. I think it's a lovely idea. I think we should all be healthy. I'm glad I don't have to personally get pap smears, but I think that's a great idea. I also think it's lovely to avoid poverty, and that if we can get at social determinants of health, I think that's great. I even think they might all be cost effective. I do not believe they will decrease costs. I don't think they're core to decreasing costs. It's good health. It's not going to save money. I will say that if you did a very, very complicated return on investment calculation on those, and you looked at effects of, say, better education across other sectors, you might come to a different conclusion. But that's not what we're talking about when we're talking about controlling healthcare costs. Finally, two more things. Clinical integration. I think this is, by and large, a really poor idea. I think it's fundamentally a label for minimizing competition, which we've shown again and again raises price and lowers quality. I think it exists for one major reason, which is politically very attractive to people who are very, very powerful. And I think for that reason we'll probably continue to see it, but not because it's going to solve the problem, but because, barring the Trump administration, which could happen, the most likely candidates are all aligned with forces who really want this to happen. Consumer empowerment, will it lower costs? And I think there are a lot of misconceptions here. I actually believe that consumer empowerment will lower costs in the context of fee-for-service. This basic story there is doctors and healthcare systems want to give you a lot of care because they make money, and empowered patients say no. If we actually go to capitation, so the economics of it are switched, so you have systems not wanting to give people care, then empowered patients are going to do exactly the opposite. And we have very good data that's exactly what happens here. The only exception would be is if the empowered patient actually chose a healthcare policy that lowered their total cost of care. However, because of adverse selection and poor risk adjustment, we are not going to have markets that work that way. And as a result, I don't think patient empowerment will do that. So I think, as, again, just like removing poverty and preventing illness, it's a lovely idea. How can you argue against empowerment? I just don't think it's going to save money.
Thank you.
Stop there.
Let's take 4 or 5 questions before giving Jeff the final word. Do I see a question? Please, Vinny.
I know nothing about economics, nor do I know much about healthcare. What I'm going to say will appear odd and perhaps revolting to some. I'm from India. Okay, it should be obvious to you by looking at me, as is Anup originally from India. I think that to me, since I've been living in the U.S. for a long time, the question that I always sort of think about is about health cost, healthcare. Who makes the decision, the individual or the society? Because there is actually a disconnect between those two. The individual in America wants every single latest thing for himself or herself, but the society can't afford it. So when you ask people, should we have nuclear power? Of course, but not in my backyard. Standard thing, right? So we talk about, for example, who decides what should be the miles per gallon of cars that we should be driving? Okay, it's pollution, it is cost, etc., etc. The individual says, I want a 500 horsepower car, and somebody will make it, and many people will make it. Society will say, this is waste. And the last point I'd make is this, using a sort of philosophical background. To assume always that health is equal to happiness is not entirely correct. I see difference in healthcare in India and the US. So in the US, India, if there's a 75, 78-year-old person who has, advanced lung cancer, people say, the doctors say, he's lived a good 75 years of healthy life. Let's sort of not try to prolong sort of his misery. Here the person says, do everything to keep my father alive for another 10 years. So I think I think we should look at other societies also. The point I'm making is this, that problems that we see in America to some extent are more or less unique to America. They're not even unique to Sweden or other places. So I haven't offered you any solution. It's just a reflection of, seeing it in a comparative sense.
Nice. Thank you.
Oh, I can't resist.
Oh my God, David's going to kill me now.
I can't resist because we're at a meeting of the Bucksbaum Institute, which presumably argues that the doctor-patient relationship matters. And I think a key part of your question, is it the individual or society, it's some combination of the two, and one of the key mediators is the physician, and the way in which they translate those decisions, and they think about, with the patient, about what is the goal of care, what are the things that you value, what is it that you want. And when the physician says, what I do is I give you this treatment, that's my role, and other than that, forget it, that's one thing. And when the physician says, what is it that you wanted, how does this benefit you, and how does our relationship do this, then I think that really can dramatically alter that. And I think, many of the people in the room who are clinically involved and have long, durable, or deep relationships with patients understand that that's a key factor in mediating that relationship and coming to terms with this.
I don't disagree at all. I think that's exactly, how the relationships sort of occur, and that is how, there is no driving force that you must do this thing.
Well, so I will just add to David's comments that I asked earlier about who is responsible for prevention, who's thinking about the life course of people, and that's in the United States we do not have a single entity that answers that question, but and so to add to what David said. Doctors right now in a lot of these financial models are actually being asked to take action, to reduce costs, to increase quality. But they're being asked by payers to do those things. So the payers really and political forces have a lot of the actual power. But doctors are expected to to really be at the point of the spear. The interesting thing is that doctors and just the regular practice of medicine are actually doing very positive things that Mr. Goldsmith highlighted, which is someone's delivering the care that has reduced cancer, heart disease, stroke, and all those things. Advances in medical care, but someone's delivering the care also, and so they're very important for a lot of doctors. Are extremely important for a lot of reasons. But, patients are also going to play a huge role in their expectations for what kind of care they want. The medical home was mentioned earlier. It is likely to be a failure in terms of an effort to reduce healthcare costs, but who wouldn't want a medical home as their source of healthcare, where you could access your doctor or provider at any time, see your lab results? All those things are the product of the medical home.
Thank you. Deb, please.
Thank you all. This is a great panel. I'm interested in, that 50% or more of our health determinants that are not in the medical establishment, but it seems like there's medical creep, because now we have demonstration programs where we know somebody's going to be healthier if they have a house to live in. So now we have demonstration programs where we find them a house. We pay for that under the umbrella of medical care. And we have Monica Peak was on WGN last week writing prescriptions for food, so patients can have that. And so we have medical creep, I think partly because, even though we have this mountain of costs and concern about health care, it still seems like it's a lower barrier to get things done in the name of health care than it is to go back and find the political will to make housing better, to make that other stuff better. So how do we begin to untangle that?
Let me jump in on that one. I wouldn't call it creep exactly. I might suggest that it's actually reality. We know that health status correlates very closely with educational status and with economic status. They're all intertwined. So saying that someone who actually has a place to sleep, a secure, safe place to sleep every night, all other things being equal, is likely to fare better than someone who's sleeping under a bridge or on the L every night, as it flies around the city is, I think, the obvious almost. Now, who pays for it and who ought to be doing that and whose responsibility is a huge, again, societal question. But these things, you know, health is not as simple as what they taught us in medical school. And in fact, more often than not, it's a whole bunch of things they didn't teach us. Now, we may have learned it somewhere else, but it's social, it's economic, it's beliefs, it's culture, it's, you know, things I can't even bring to mind right now.
Yeah, you know, I go up to Canada occasionally, and it's hard because you look at the comparative health status indicators and the relative efficiency of our health system. We look terrible, and I get the crap beaten out of me, and I always sort of push back and say, well, what would your numbers look like if you had 500,000 people sleeping under bridges and 40,000 gun deaths and 49,000 people dying of drug overdoses? We have a crazy, dangerous culture, okay? And that culture, the way our social accounting system works, all of the costs of that culture end up on the ledger of the care system. And, you know, if I were, you know, a creative governor, I'd say, well, geez, you guys have all this money. You're really powerful. You have influence over a lot of stuff. Why don't you guys fix this with some of the money we're giving you and all the money you're making, taking care of all this mess? So it's sort of like, it's really hard to travel abroad and to see societies that are safer, saner places that have less health spending, and we get blamed because of our care system. That pisses me off.
Mike, the last question, go ahead.
Oh, thank you so much. Thank you for everybody. It was an outstanding presentation. I hate to follow Dr. Kumar because once a pathologist has seen your patient, it's usually... I went into medicine because I know nothing about money. I went into academic medicine because I know absolutely nothing about money. It seems to me that part of it should also include doctors need to take back medicine. We need to be involved at a higher level. We shouldn't have young, energetic CMS people making decisions about how we treat our patients. And I think that we have to figure out how to train our medical students to be involved and to be involved in the decision making before it gets filtered through many, because it wasn't very exciting to hear about how successful this has all been. And the final one I would add to Jeff's comment about what else we're not thinking about. End of life in the ICU, I think, is important. And I think we can't forget about tort reform. So much of the care that is provided in ICUs and is about preventive defensive medicine. I don't want to get sued. I know this MRI won't show me anything. I don't already know for $3,000, but the family's insisting that I do it. And I think that we could also address the cost of medicine through that avenue.
Jeff, I'm going to give you the final word.
It's hard to, you know, directly respond to all the, you know, I think really thoughtful comments that you were in this panel. I'm not going to do that. I've worked in our health system for 40 years, and a lot of it has been in places like this, in complex places, very expensive places, incredibly complicated places. And I guess my experience in the last year of being a patient has really been kind of stunning. And I don't buy the idea that I was sitting there trying to maximize the amount of resources I was consuming to avoid pain. That wasn't my concern at all. I was trying to get control back over my life, okay? And what I was looking for from the doctors that were working with me, and I got it, was tell me the truth. Tell me the truth. Answer my questions. You know, be an advisor to me. Help me learn from you how I can do this, how I can get my life back. And, you know, and I got really great medical care and really stellar relationships that were engendered in that process at all different levels of the care system. I really came away a whole lot more optimistic. I wasn't looking for, you know, give me all these drugs. I don't want to have any pain at all. I didn't want all those drugs. I didn't want to be in the hospital. I want to be at home. I mean, it's not like I was sitting there trying to maximize the amount of care I used. That wasn't it at all. And, you know, your comment about, you know, the doctor, I mean, I don't want the doctor working for some vast conglomerate with someone whispering in their ear what to do. I want the doctor to work for me. And I want him to tell me the truth. That's what I want. And I think there are a lot of people out there that want that too.
Beautiful note to end on.
Absolutely.
I want to thank everybody for coming in. Thank you.
Right. Good job, guys. Hey, it was really good to